reading. Let's pray. Father, indeed, we thank you for our time together tonight. We just pray that you might give us information that we need, and that as we give the information, the Bible says, help us to do the word, not just hear. We thank you for what you're going to do in this set. In Jesus' name, amen. Amen.
All right, as you know, September, we have a lot of cancer awareness that we're talking about. And tonight, our speaker, Ms. Judy Wells, is going to speak to you about leukemia, multiple myeloma, and thyroid disease and cancers. Okay, just a little bit about Mrs. Jenny Wells. Jenny Wells has over 35 years of experience in adult oncology and nursing. Her national certification in oncology nursing from the Oncology Nursing Society, and she maintained that since 1991. Ms. Judy has a master's degree in education from the University of Mississippi School of Nursing in 1998. So she has a plethora of experience behind her. She's a longtime volunteer for the American Cancer Society and the Mississippi Partnership for Comprehensive Cancer Control in the Mississippi Department of Health. And she also has roles on the statewide coalition chairperson for that coalition. Currently, she serves on the Mississippi Lung Cancer, the HPV, and the Colorectal Cancer Roundtable. Mrs. Wells is retired from the University of Mississippi Medical Center after 28 years of service. Thank you. Currently, she's employed part-time as an oncology nurse navigator and an educator at St. Dominic Hospital here in Jackson, Mississippi, along with her congregational health nursing endeavors. Ms. Judy Wells is married to Mr. Tony Wells Sr., and they are the proud parents of 3 wonderful children and are blessed to have 2 amazing grandsons, Mason and Miles, as she lovingly affectionately calls them her Indians. Okay, so let's welcome Ms. Judy Wells to give us a presentation tonight.
Well, I want to say good evening to everybody that I've just spoken to, and I want to thank the Lord for the invitation. Anytime that I get an opportunity to share, I'm so thankful and I'm appreciative. And this is, when she asked me the subject and the subject matter, because you hear about the regular, everybody hears about breast cancer. Hopefully you're hearing a lot about that, prostate cancer, lung cancer, and that's wonderful. You do need to hear about all of those things. But tonight, Ms. Laura asked me to speak on a subject or some topics that you don't normally hear a lot about. So the subjects or the topics, the diseases, that I'm going to talk about is thyroid cancer, because you don't really hear. How many of you have heard someone that had thyroid cancer? Usually 1 or 2. That's about average. And then talking about leukemia and multiple myeloma. I threw lymphoma in there just because it's also one of those kind of blood lymph node cancers. But we're going to talk about that, and that's why I chose that. But I wanted to start off because everybody has a definition of what cancer is and where it comes from. Basically, cancer is an unregulated, disorganized growth. That's that second slide that you have, is unregulated, disorganized growth. And all that other stuff is true, but the basic concept behind any kind of cancer, no matter what kind it is an absolutely normal cell that was doing exactly what it was supposed to do, and then all of a sudden, I call it got stuck on stupid. It just got stuck on stupid, and it started growing, and it did stop, because normal cells have a normal shutoff. You make so many, and it shuts off. Cancer cells get stuck on stupid, and again, they're perfectly normal cells that for some reason the normal shutoffs don't work. So when you flip that over, so this is how the changes happen. What happens with cancer? You have one cell that changes, and you have this disorganized growth that goes on. The normal shutoffs don't work. And when that happens, and this is the thing though, is that happens, or theoretically that happens millions of times in your life cycle, but your body's immune system most of the time shuts that down. That there are natural things that happen in our bodies that can stop that process. But for some reason, when cancer pushes through that, and it actually becomes a cancer, that's when you have a malignant transformation. That's where it turns into a cancer. And then the other thing that's particularly different about cancer is that you can have growth, like if you have keloid skin, or if you have fibroids, they grow as well, but wherever they grow is where they're going to stay. They're not going to go anywhere else. Cancer has the ability to go from wherever, it won't stay where it starts. It can go anywhere in your body. So those are the changes. One perfectly normal cell got stuck on stupid, the normal shut-offs didn't work, and it kept going. That's what cancer is. No matter what kind of cancer it is, all of it starts that way. Every last one of them. So some basic facts, I could not, as an educator, come before you and not talk about some basic facts about cancer. So first of all, cancer is the second leading cause of death in the United States. Out of everything that people die from in the United States, cancer is number 2. Number 1, of course, is heart disease. It causes 1 in 5 deaths in the state of Mississippi. I would have to guess, even though we're not mighty in number, that each and every one of you know someone that lost a battle with cancer, or actually was victorious. I like to talk about that too, because we're having a lot of victory laps now when it comes to cancer. Everybody in this room knows somebody. The thing though, for most cancers, we always talk about early detection, and that's what you hear a lot about, screening and all that. I will say that the cancers that I'm going to talk about tonight, they don't have screenings for those. That's why you don't hear a lot about it. You don't hear about screenings for thyroid cancer. You don't hear about screenings for leukemia and myeloma. There are no screenings for those diseases, but most of the others, you have screenings for those. But then the other thing is that when you start talking about cancer, it is not a cheap experience. Whether you have insurance or not, whether you come from money or not, it is a very expensive process. The one thing though I want to spend just a minute on is that when you talk about cancers, there are basically 2 broad groups of cancers. There are cancers that come from what we call solid tissue, like breast, bone, prostate, lung. Those are what we call solid tumor kinds of cancers. And then you have the other side of this, cancers that come from the blood, or the lymph system. So when you talk about solid tumors, they typically, the way they grow, they start small, and you can find it small. You can find it in one place. And typically, they have a symptom that let you know something is wrong. So if you have a lung cancer, you have it start in one place, you get short of breath, you have a cough, you have all those symptoms. If you have breast cancer, you feel a knot, and it grows, and that kind of thing. If you have colon cancer, you may see some blood in your stool and your urine. So there is a symptom that lets you know something is going on with that particular part of your body. That's a solid tumor type cancer. And when you talk about those kind of cancers, most of them, not all, but most of them have some kind of screening that we can find it early. Because in those kind of cancers, when you find it early, you can actually do better with it. That's in that early stage when they talk about doing all those screenings. So, but on the other side of the coin, blood cancers. Blood cancers come from the blood or in the lymph system. So just like you have a blood system that runs throughout your whole body, there is a lymph node system that actually runs parallel right along with your blood. So you have a whole system in your body, lymph nodes and blood. So they're all over your body. The thing about that is if you, I tell people this, and I teach classes for nurses, you can have a little bit of breast cancer. You can find it, you can have a little bit of it. There's no such thing as a little bit of leukemia. It's like being a little bit pregnant. Either you are or you don't. Either you have leukemia or you don't, because it's in your blood. So you don't have blood in just one spot. So blood circulates all over your body. So if you have a leukemia, it's either you have it or you don't. If there's not a screening for it, the other thing about these blood and lymph nodes kind of cancer, you don't necessarily wake up and say, oh, my blood doesn't feel right, something wrong with your blood. You know, you can wake up and say, oh, my hip is hurt, or I can't urinate this, so something going on with the prostate. That's not what happens with those blood and lymph nodes kind of cancers. They don't present like that. You don't wake up and say, oh, my arm is hurt, there's something wrong with my arm. It doesn't work that way. What happens with those kind of cancers, they present differently, and I'm going to talk about that. So totally different. And I really wanted us to key in on solid tumors versus blood and lymph node type cancers, because you hear them differently. Now, the one solid tumor that I am going to talk about tonight is thyroid cancer, first of all, the thyroid itself, because I wanted to kind of share that. What it does, the thyroid basically is located here in your neck. It's kind of like cervical around where you're swallowing to, where your esophagus is down there. It's usually on the side, kind of at the bottom base of it. Everybody's got one. Hopefully you can't feel it. Hope, ma'am. Yeah, it kind of circles. It kind of circles around. I think I have a picture on that next slide. So it kind of fits on either side. It kind of goes around to almost like a necktie. Almost like a necktie at the base of your throat. So whenever you go to the doctor and they do this, they feel up here, then they go down, and they come down, they feel right in there. They're feeling for your thyroid. They don't ever say anything, but they're feeling for it. Because guess what? You really shouldn't feel it. Or if you feel it, it should not be something that's very subtle. You really shouldn't feel much of it. But what the, yes, sir.
Are they feeling for a knock?
Yes, sir.
Okay, so knock on there.
Not necessarily on the here, because that's something different. Thyroid's a little bit further down. It's a little bit further down, kind of like right in there. Almost down there where you're down in there. That's kind of, now it kind of goes up a little bit and kind of down, like a towel. But it's a little bit further. It's not right there underneath your chin there. It's not there. It's a little bit further down. It's where it's located. So when you go to the doctor, if you got a good one, he's going to be doing this. You know, they go on your jaw, and then they come all the way down your neck. And so what they're feeling for when they come down your windpipe is that they're feeling for your thyroid. That's what they're doing. So what is the function of the thyroid? You know, you don't feel it. You don't know that you have it. It doesn't, as far as we know, it's not really doing anything. But what the thyroid does, it produces hormones that control your metabolism. Basically, how your body processes energy. That's what the thyroid does. It also aids in digestive function, muscle control, and mood regulation. So, you hear people say, I'm on thyroid medicine, Synthroid. I got my thyroid works too much or it doesn't work enough. Either hyper or hypo. So typically people that have hypo, meaning that it doesn't work good, it's slow, metabolism is slow, those people tend to gain weight easy. They don't have a lot of energy, that kind of thing. People that hyper, that is working too much, those people are usually really thin. So that's kind of the function of it. I wanted to, because people don't talk about thyroid. So that's the normal function of the thyroid. But what happens is that, again, that single cell gets stuck on the stupid. It just happens to start in the thyroid. So when you go to your doctor, when you are taking your bath or taking a shower, and you feel your neck, if you happen to feel a bump or a lump, and especially if it's a little bit lower down, that doesn't mean that, oh my God, something's wrong, but it does mean you need to go get checked. That's the first symptom that you would know of a thyroid cancer. The thing though about thyroid cancer is that if you find it early, it's 100% curable. You can cure thyroid cancer. The thing though, the trick is that typically there are no symptoms when you're really early on other than feeling that little knot. It's hard to feel when it's really little. That's why when you do your annual checks, even though your doctor may not say anything, or your nurse practitioner, whoever it is that you're seeing, and hopefully you are seeing someone on an annual basis, they don't say anything, but they feel around my people. That's what they're feeling for. But if you happen to find one 6 months after, call them and say, you know, I think I found something. Can I come in and let you check it? That's the smart thing to do. But later on, if you don't find it early, if your doctor doesn't find it, what happens is that there's a lump that can happen in your neck. You can have difficulty breathing, difficulty swallowing, because again, it's right there by the windpipe, and there's where you swallow your esophagus. And if it gets big enough and it starts pressing, that's how you can have difficulty breathing and swallowing and all of that. But the thing also about thyroid cancer is that we really don't know specifically, you know, like lung cancer. We know that if you're a smoker or exposed to tobacco, those kind of things will impact you as far as having lung cancer. We know that. But with thyroid cancer, we don't know any one particular thing that you would do that would put you at increased risk for having thyroid cancer. But if there are a couple of things that we do know. If for some reason you had to have radiation therapy for another diagnosis or for something else, that actually can cause your thyroid to not function well, and that can actually turn into a thyroid cancer. So previous radiation therapy to the neck or head area. Also, if you have a family history, if somebody else in your family had a thyroid cancer, that's important to share that information. Doesn't mean that you will automatically get it, but that's a conversation you need to have with your doctor to say, you know, my grandma, my whomever had it. Then they want you to tell your doctor that's let you check for it. So that's pretty much it. So the treatment as far as thyroid cancer is concerned, basically if you find it early, they can either take it out surgically or they can do a radiation treatment. Both of those treatments basically either by medicine, by surgery, or by radiation therapy, all three of those procedures can actually completely get rid of it if you catch it early. So that's kind of what thyroid cancer is. So the takeaway from thyroid cancer is just that if you feel like you got a knob or a lump or something down here at the base of your throat, now don't make yourself sore. Don't be digging too hard, but just kind of casually, if you touch it and you feel something that's on one that's not on both sides, then just call the doctor and say, can you check this for me? That's the thing to go with that. So that's pretty much it about thyroid cancer. Anyone have any questions about thyroid cancer? Yes, ma'am.
My question is, usually when you go to the doctor and do blood work and all that, so they tell me they won't be able to detect that.
Not from blood work, no ma'am. Not from blood work.
Is it hereditary?
No ma'am. It's not been shown to be hereditary. But the thing is people ask about it a lot because there are things that go on in your family, but it's not necessarily passed on genetically. There are certain things that run like high blood pressure, they run in your family, but it's not, if you do a genetic test, nothing is going to show up. So there are two different windows. So people are asking about that a lot, about do I need to get a genetic test? There are only about 10% of all cancers are passed genetically, only about 10%. So that's a very low number. There are some that we truly look for, that we have some good markers, but most cancers are not passed on genetically. A few are, but most of them are not. So for thyroid cancer, there is not a genetic test for this one.
But it could, let's say, I'm asking because I'm thinking about my husband and my daughter. Suppose you have been diagnosed with thyroid disease or something, and I'm taking medication. Like my husband did, I remember playing with he had the thyroid shower. I could just see him getting smaller and smaller. But he had medication for it. Come along now, his daughter, my daughter, she was having the same problem. And my granddaughter, that's why I'm asking if it's hereditary, because it's.
Now, thyroid disease and thyroid cancer are two different things. But yes,
That's why I mixed up. Thank you.
yes, thyroid cancer and thyroid disease are two different things.
Right.
Thyroid disease can be passed in the family, and you treat it just like you treat high blood pressure. So it is important to have those conversations, though, so that your daughter and your granddaughter know what symptoms to watch for. So thyroid disease, taking Synthroid and regulating that is different. That's thyroid disease. Thyroid cancer is actually a cancer itself that will continue to grow. Grow and grow and grow and basically spread to other places. I'm glad you asked that.
And when you're going in for treatment, they would determine whether it's the disease or not.
Right. If it's the disease, the way they can tell whether or not it's disease, they draw thyroid stimulating hormone. There's a blood that they can draw. They do draw blood for that, and it should be at a certain level. So if it's too high, that's hyper. If it's too low, that's hypo. And they can regulate that with medication. So that's different. That's not going to grow. There's not a lump or not. It's just a function of how it works has changed. It is no longer producing the right level of hormones that it usually does. So that's thyroid disease. Thyroid cancer is a lump or not. It gets bigger and spreads to other places. It can ultimately take your life if you don't do something about it. I'm glad you asked that. That's why I love small groups. You get to really share. Okay, we're good. All right, so now.
Family, so it runs in all different kinds, kind of running my family. That's why I was glad that my friend and neighbor, Diane, put it out that it was happening here tonight. So yes, I need to go and learn as much about cancer as I can.
Exactly, and that's important. We're going to talk about that, how important it is to have these type of conversations, not only in this group, but especially in your family. it is very important to have those conversations about what runs in my family. If it runs with thyroid disease in your family, or high blood pressure, or stroke, or a particular kind of cancer, that is critically important to have that conversation, especially when you start talking about those solid tumors, those breast, the prostate, the colon cancers, and things like that. Those are important for you to have those discussions with all members of your family. So that's the one solid tumor that we're going to talk about. Now we're going to switch lanes and talk about these blood cancers. Talk about these blood cancers. So what are blood cancers? They affect your bone marrow. And so what your bone marrow is the part of your bones that's inside of your bones. That's where all of your blood is produced. That's where all of your blood cells come from. And I call it the factory. The bigger the bones, the more it makes. So the big bones in your hip, the long bones in your leg, they have a lot of space in there. So that's a big part of the factory, but all of your bones, the inside of all of your bones is where your bone marrow is. That's why all blood cells are made. And basically there are three major types of blood cells that come out of your bone marrow. Red cells, you have white cells, which are the ones that fight infections, and you have another one called platelets, and they kind of help you to stop bleeding, like cut yourself. Platelets are the things that give you the ability to not bleed too much. So all of those cells don't come from inside of your bones. So blood cancers start in the bone marrow. They affect your blood cells. And they can either be red cells, they can be the red, white, or most of the red cells are the white cells, or where these cancers come from the blood cancer line. So when you talk about blood cancers, and again, we hear about the breast and lung and prostate, but you don't hear too much about these blood cancers. Approximately every 3 minutes, someone in the United States is diagnosed with blood cancer. That's a lot of people. We have almost 190,000 people that will be diagnosed, or that were diagnosed in 2024 with a blood cancer. And then when you look at it, while the number itself is not as large as some of the other diseases, these diseases are really, really difficult sometimes to diagnose, and definitely can be very difficult to treat. So when you're looking at it overall, though, that now that the technology, and I would say for all cancers in general, the technology is so much better. I've been doing cancer nursing for a long time. I thought about it a few weeks ago. Next year will be my 40th year doing something with cancer nursing, and I can tell you the changes and the advances that I see now are just, I would never even have dreamed how much better it can be. Now, there's still some bad players, there's still some bad things that go on with cancer, but because of all this new technology, we see other things that are happening as well. So when you go over to the next one, it talks about different types of blood cancers, or cancers that come from the bone marrow. The main one that we're going to be looking at is leukemia. In September is Leukemia Awareness Month, and we're going to talk about that a little bit. With leukemia, the way it presents, leukemias are also one of the primary cancers that children are diagnosed with. Pediatric cancer, children are oftentimes diagnosed with leukemia. So you can have pediatric or childhood leukemia, or you can get leukemia as an adult. The other one that not necessarily she didn't ask for, but I just kind of put it in there, the other kind of cancer that comes out of the bone marrow is a cancer that comes from the white blood cell line. That blood cell line that fights infection, and that is lymphoma. Lymphoma. You have young people get a certain type of lymphoma, and then older adults get a different kind of lymphoma for the most part. And then you have something called myeloma or multiple myeloma. We're going to talk about each one of those individually. Yes, ma'am. What the marrow inside the bone? It's the marrow. It's the part of the external part of your bone is really hard, and it's your skeleton that keep you upright. Your bone marrow is the inside of your bones is really mushy. It's really mushy. But that mushy part, that's the factory where all of your blood cells are made. So everything, every blood cell that you have in your body from the time before you were born, it came out of, it is produced in your bone marrow. And your bone marrow, once they become mature, they stay in the bone marrow and go in the factory. I call it the factory. When they're mature, then they come out. They either come out in your blood vessels, in your veins, and your arteries, or they come out in your lymph nodes. You know, kind of underneath your chin, you feel a little knots, that's a lymph node. So they either come out of your bone marrow, going into your blood cell, your veins, or your arteries, or they go into your lymph nodes. So everything starts in the factory, though. So when you talk about what those blood cells do, your red cells carry your oxygen. So if you're short of breath and you don't have any energy, you're pale, the inside your lips, you're kind of gray, that kind of stuff is when you have a low, when you're anemic. Everybody's heard about being anemic and how you feel when you're anemic. So if your blood cells coming out of your bone marrow don't work right, your red cells don't work right, you're going to have anemia, you're going to be tired, you're not going to have a lot of energy, you're going to be short of breath. If your white blood cells that your bone marrow is making don't work right, that means you won't be able to fight infection. You'll get infections at the drop of a hat and you can't fix it and you won't get better. So the bone marrow itself, the mushy inside of your bones, is that factor where every blood cell in your body starts out there. Yes, ma'am.
So, I know people with multiple myeloma, and the major thing that when they found out was fractures. So, just trying to understand that.
Wait, I'm gonna get there. I'm gonna do each disease, and we're gonna talk about how they present, and we'll talk about how with multiple myeloma, how they see fractures and they manifest in the bone. So we'll get there.
If you break it's all in that brown stuff.
That's marrow. That's marrow. And if you, now, my husband, he loves the food channel. He loves the food channel. Now, I watch HGTV. He claimed he's going to be a wild broken down by the time he come home. But he loves the food channel. So when you know them fancy restaurants that they have on there, they actually serve bone marrow. They have the big old bones, and they have people eating the bone marrow because it's really rich. They used to chew them chicken bones, and they would chew them and chew that marrow because it is really rich and full of nutrients, because it's powerful with a lot. That's where the blood cells come from. So that's exactly, see, I love this because we got some stuff going on. But we're going to get there, I promise. Yes, sir.
To talk about the bone marrow. Is there anything we can do, diet, or anything we can do to affect it?
No, sir.
So just
It's an automatic process that you don't control. You remember when I talked about the solid tumors, there are things that you can do, and there's screening that you can do. There's things that you can do to make it healthier. There are lifestyle things if you eat right and then exercise and you get screened, you can do something about all those other kind of cancers. With these blood cancers, no, sir. There are a few situations that I'll talk about that's disease specific, and that's the thing. That's a problem with these blood cancers. Outside, and I'm going to talk about those situations that can actually increase your risk, but for the most part, you just live in life and it hits you like a train coming. There's no warning. There's not something that you can do to change this trajectory. There's not something that you can do to prevent it. So, talking about leukemia, let's start there. There is no screening. Like you've got mammograms, you've got PSAs and digital rectal exams and colonoscopies and all of these things. There is no physical exam to tell you whether or not you got an early stage leukemia. It doesn't exist. So what is leukemia? Remember I said the factor is where everything starts. It gets to be mature cells, and when they get to be adult mature cells, they come out of your bone marrow and they go in your bloodstream. What leukemia is, remember that stuck on stupid? Leukemia is baby cells that are inside your bone marrow. They get stuck on stupid, and instead of your bone marrow producing healthy, mature adult cells, it starts overproducing all these baby cells. These baby cells are called blast cells. So when the bone marrow starts producing all these baby cells, and it puts out these baby cells, your body can't use them. They're no good. They're babies. It's like having a 2-month-old trying to direct the choir or trying to preach a sermon. It's just not going to happen. They cannot function in that way. So leukemia are all these baby cells that get released from your bone marrow, and then you're circulating blood, and what ends up happening, these baby cells, they produce so many of them that you no longer have any good cells left. So all you got is the baby cells floating around that you can't use. And so the way that happens is that when you go to the doctor, you're like, oh, I'm so tired. I don't know why I'm so tired. I just can't get no energy. Or you go to the dentist and they take a tooth out and it won't stop bleeding. Or you got a bruise on your arm and you know you didn't do anything. So what has happened is the factory. Remember, the bone marrow is the factory. So, but instead of the factory producing healthy white cells, red cells, and platelets, it's spitting out all these baby cells. So you're not making enough white cells, you're not making enough red cells, and you're not making enough platelets. All you got is immature baby cells. So your body can't use it. So what you see on the other end, once you get flooded with these baby cells, you tired a lot. You get infections that you can't get over, and you have bruising and bleeding and all that kind of stuff. But you don't think, oh, I got leukemia. You think, I don't know why I'm so tired. I think I'm anemic. So that's one of those things. It's like a shot in the dark. There's not something that can tell you this is what I have. And the way that they find it, they draw some blood. And when they draw that blood, they check your blood count, and they're checking your blood count. If they see those baby cells in your peripheral blood, they know it's leukemia. They don't know what kind. But if you see baby blast cells in a CBC, which is a complete blood count, that's leukemia. Now, there's a lot more things they have to do to figure out exactly what kind it is. But that's how you diagnose it. There's no screening. There's nothing that you can do. Now, if this does not happen, thank God. Thank God. This does not happen as often as you see a lot of those other cancers, but it does happen. It does happen. So once you present with those symptoms, or someone presents with those symptoms, you end up going to the doctor and say, I'm just tired, I don't know what's going on. They draw CBC and they're like, oh, this is not right. And then they send you somewhere else. Because they saw those cells in your blood, they don't know exactly what it is, but they know that's not supposed to be there. So they send you to a specialist. And the way that this specialist can tell what kind of leukemia it is, they have to do what they call a biopsy. And this is a bone marrow biopsy. They actually have to put a needle in, and they usually go in your hip, or they can go here in your chest because those are big bones. And they put a needle in there, and they actually suck out a little bit of that bone marrow. And they put it under a microscope. Yeah, you got some good medicine on board when they're doing that. Yes, ma'am.
My husband has AML.
Ah,
And he has it now for the second time.
okay.
It was through remission. And now they just found out that it's come back. And they did biopsy. So what is that?
Yeah, and then get right here.
I guess
Yeah.
I was watching it. And yes, I saw the stuff. It pulled down in the wall. I know we haven't gotten to it yet, but I'm just curious because I keep reading this. It says here biotherapy.
Yes.
What is biotherapy?
So biotherapy, what it is like traditionally when we have a cancer, we have traditional chemotherapy. And chemotherapy is the drugs that make you sick, make your hair come out, mess with your blood counts and all that kind of stuff. What biotherapy is that we've had it around for a lot of years now, but what biotherapy they did, so chemotherapy, I tell people chemotherapy is a stupid drug. It doesn't know a good cell from a bad cell. It's just gonna kill anything that's growing fast.
That's basically what the doctor had said, it just kills everything.
Everything.
And he'll be found back in the hospital, to get chemo again for 10 days.
Mm-hmm.
And I would get something else.
Mhm.
And I was just curious what biotherapy.
So biotherapy is different because they went back to the lab and said, okay, let's just really think about this thing. When all cancer has to have something going on that supports it, whether you intentionally want to support it or not. There's some basic physiology that goes on that keeps that cancer supported. There's some basic stuff in our body that either the cancer makes us overproduce or we don't have enough of it. So what they've done, they've studied these different diseases and they found out, oh, this kind of cancer makes this kind of stuff go up. Or this kind of cancer, this is what you see on this kind of cancer. So what they've done is that they developed drugs that are specific for particular things on particular kind of cancers. So if your particular kind of cancer has it, and this is just something called CD20, that's just like a protein. There are different proteins on different things. So if your particular kind of cancer produces a lot of CD20, so that means that I make a drug that's only gonna mess with CD20, it's gonna be specific for your kind of
Now,
cancer.
that's funny that you mention that, because she is looking for 3 different points. She said, I guess, what up to the pathology.
Yeah, the markers.
Markers, and said she was looking for 3 different markers, and if she could find one of them, she would be able to give him a pill instead of sending him out to the hospital for the chemo.
Right.
See, every time he goes to the clinic, his platelets are always like way down.
Mhm.
And he ends up getting like 2 bags of platelets. This is 3 times a week now.
Right.
So she knew something was up.
So what, and just kind of just for full disclosure, one of the things that I did before I retired from the medical center is that was one of the areas that I worked in almost exclusively, was taking care of leukemia patients and the drugs and all that, and even did bone marrow for a while. So what typically happens with leukemia, even with treatment, the way you treat leukemia is that because it's a disease that is coming from the factory, you got to completely eradicate, you got to tear up the factory, you got to completely clean it out. You got to give drugs that completely destroy the factory. You got to give drugs that are going to completely shut down the whole function of the bone marrow. So what that means is that the chemo that we give you is going to make you terribly sick. But if it doesn't, the leukemia is going to take your life. So the goal is we got to clean it all out, good, bad, and the ugly. Everything's got to go. And you give all these drugs, you make them really sick, and the prayer is when it starts to grow back, it grows back without the leukemia of the blast cells. But the thing is that when they've gotten those heavy drugs, your bone marrow don't snap back real easy. It's like, that's a heavy hit. That's like getting hit on the head with a 2x4. It shakes up some stuff. And so the bone marrow does not work the way it did before he had leukemia. So it just didn't work right. So the fact that he had to continuously get platelets, that let the doctor know something right.
Yeah.
It's not perking like it's supposed to perk. So now, with the cells coming back, those baby cells reproducing again, and that's the other thing about leukemia is that they are tenacious. You can kill it with a stick and it'll come back. It'll come back quicker than some of the solid tumors. So that's where your husband finds himself. But you have an excellent doctor, because while we know traditional chemotherapy got rid of it, but it made him so sick. So she's trying to find a treatment to see if he's going to be eligible for one of those biotherapy drugs.
Right.
Because she's looking for certain markers. There are certain drugs that go with certain markers that don't have the same effect, don't have the same side effects as this chemotherapy. Does that make sense now? If you don't mind me asking, who's your doctor?
Dr. Bill Burnett, she's done.
I love her.
Oh, we do too.
I love her. I've been doing this long. I remember when Dr. Miller first started her training. I was there when she first started. Tell her Jimmy said hello next time you see her. So that was a whole sermon about leukemia. So basically with leukemia, you get your chemotherapy, biotherapy. In some patients, depending on what kind, they can also get a transplant. It just kind of depends. The AML, typically, a lot of times they don't necessarily get transplants because there's just too much involved.
Yeah.
There's another group, acute ALL, which is acute lymphocytic leukemia. That's a different animal as well. So there are a lot of subcategories under leukemia. And when you look at that, as far as types of leukemia, there are 2 broad categories. There are acute leukemias, and there are like several subcategories under acute. Then there are chronic leukemias. There are several categories under chronic. And they're exactly what they say. Acute is right now, you can't ignore it. It's not going to let you ignore it. It will take your life in a matter of
That's
weeks.
what he has, had acute myeloid leukemia.
And then chronic it's not a fun,
Oh, right.
it doesn't go.
You can only treat it.
You can treat it, you can treat it. Then you have the chronic side. It is just like what it says, it's a chronic disease. For the most part, you can keep it controlled.
Yeah.
So with that, again, with who gets leukemia, children, this is the most common cancer diagnosed in children. But the thing about children, childhood leukemia oftentimes is very responsive to treatment. Especially there's a leukemia, acute leukemia called ALL, acute lymphocytic leukemia. Children get that and they actually have a treatment, and children do fairly well and actually can live long term with or post a diagnosis of childhood. Adults, it's not so much. It depends. It really depends. AML is the toughest one. But then there's subcategories under that AML. There's acute promyelocytic leukemia. There's acute lymphocytic leukemia. There's all these subcategories underneath there, and every one of them have a little bit different tag as to what they do. So APL is an acute leukemia that actually responds fairly well to treatment. So every one of them is different, and when I tell you, back when I was doing it, we only had 2 or 3. They found about 5 or 6 different ones now. These subcategories that are all in all these markers that they find for these different diseases will tell you how aggressive it is. A lot of times it will tell you even what drug therapy that you can try with those diseases. Survival has improved, definitely with children, and even with adults, it does get better. It has gotten better. There are still some bad players. AML is a tough beast. It really is. It's a tough beast.
She's warned us about that. I
And-
know where it's going.
I know. And that's the thing, you want somebody to be honest with you,
Well,
but
that's it with her. She's very honest.
Yes.
You know, she's very straightforward, very honest, but she's sweet. She really is.
and she always has been. You can tell the good ones when I tell them you can tell the good ones when they get out them short coats. When they when they become real doctors, you can tell which ones are going to be good, but she was always one of the good ones.
Yes.
She was always one of the good ones. So that's, there. We could stay here for a week talking about leukemia, but I just wanted to at least give a brief overview that it comes from the bone marrow. It's where the bone marrow gets stuck on stupid and it puts out all these baby cells, these blast cells. And when those blast cells are being overproduced, nothing else is being made in that bone marrow. And that's why you have infection. That's why you have, you're tired. That's why you have bleeding. Nothing is being made when the leukemia is in the house. So that's what happens with that. Moving on to any questions about leukemia?
I'm sorry.
No. Go ahead. Do you have another question?
What was the question?
I said, did you have any other questions about leukemia?
Oh, no, ma'am. Thank you.
Hopefully I helped a little bit to help clarify something that Dr. Miller was already saying, or at least kind of reconfirm some of the stuff that she'd already told.
Yes, you did.
Awesome. That's
And I
good.
appreciate it.
That means I'm telling the truth, so y'all got it. I really like that though. I like the give and take because that validates so that the folks that are with you is like, okay, she was actually telling us the truth, and that is important to me. I want to make sure the information that I'm sharing, first of all, is accurate and that it's something that is understandable and that you can take it and use it. Okay. Looking at lymphoma. This one that Mr. Bora asked about. How much time? I need to talk about. Okay. All right. Y'all tell me to sit down. I talk too much. I talk a lot now. Lymphoma. Lymphoma is another one of those cancers that come from the bone marrow, but it comes from the white blood cell. Whereas leukemia affects the whole bone marrow. Lymphoma typically comes from the white blood cell line, basically coming out of those lymph nodes, which is where our body warehouses throughout our whole body. It's kind of a warehouse where those white blood cells are stored. So you have an overproduction, just like leukemia, you have an overproduction of these non-functioning cells. They just don't work right, but it's in the white cell line. The thing though about lymphoma though, unlike leukemia, it's just gonna always be in your blood, it's not gonna necessarily form a tumor for the most part. Lymphomas can actually form tumors. They can solidify into a mass. They're usually somewhere near or on or in your lymph nodes, but they can get to be pretty big masses that they can form. Typically, there are two broad categories of lymphoma. There's a type of lymphoma that typically young people get, or younger, older teenagers, young adults, and that's Hodgkin's lymphoma. Hodgkin's lymphoma is the one that younger people tend to get. I call it our seasoned saints. We tend to get a different kind of lymphoma, and it's called non-Hodgkin's lymphoma. The difference is basically it's still cancer. Typically, though, Hodgkin's is something that once it's diagnosed with younger people, they tend to actually do fairly well if you can get it under control. For the most part, you can. So a lot of young people, young adults, people in their late teens and early 20s is where you typically will see Hodgkin's disease. Non-Hodgkin's are typically older, 50 or above. Different animal, different beast, and with that one you can control it. A lot of times you don't necessarily get rid of it, but you can control it. The treatment for lymphoma is a combination of things. Typically the combination is going to be chemotherapy or a biotherapy because they look for markers, those things that stand out that this particular kind of cancer makes, this particular overproduces a certain kind of protein. So they look for that. Now, a lot of drugs out there now for lymphoma because they found these markers on those lymphomas and they combine traditional chemotherapy with these biotherapy drugs. Sometimes they will offer radiation therapy. It just kind of depends on how much disease is there as to what they're going to be offered. But lymphoma, again, comes from the white blood cell line. They generally are manifested in your lymph nodes, so they can be anywhere in your body. Typically, you will see them mostly in the chest and neck areas where you typically see those at though. And treatment, once diagnosed, again, other than you feeling a lump or not, now it can produce itself and manifest as a lump or not. Typically in the neck, sometimes you'll see it there. It also can be in your chest area. It can be anywhere, honestly, but that's kind of where you will see it, where you can actually see a difference as for something that you can take yourself. So that's pretty much it on lymphoma. I just wanted to throw it in. So leukemias affect the whole bone marrow. Lymphoma comes from the white blood cell and basically in your lymph nodes. The third one is myeloma, and a lot of times people say multiple myeloma. This is another disease, another cancer that comes from the white blood cell line. The one part of the white blood cell is something called plasma cell. Plasma cells. So again, stuck on stupid. Instead of becoming a mature, healthy white blood cell, it's stuck in the plasma phase, and then it starts to overproduce these plasma cells, which body can't use because they're not normal. And they can induce foreign masses. The thing about multiple myeloma, typically it happens in the bones. In the bones. Somebody had that question when we first started about multiple myeloma, their bones are weak. Those cancers and those tumors, it does manifest as a tumor. And basically, it replaces the hard bone and makes them really mushy. And it's actually cancer. So their bones are really weak and they can break bones really easily. So myeloma is the cancer that actually is in the white blood cell line. It's plasma cells is what they look at and what they call it. It's overproducing those plasma cells. And those plasma cells will typically show up in your bones, the hard part of your bones, not the inside of the mushy bone marrow. It's the hard part of your bones, so those bones get really mushy, and they'll break really, really easily. The other problem with multiple myeloma is that because it gets inside your bones, typically your bones carry a lot of calcium, so it pushes the calcium outside of your bones into your bloodstream, and when you got too much calcium in your bloodstream, that's a bad thing too. So it's just this multitude of things that are going on with multiple myeloma. So it damages or weakens your bones. So who gets multiple myeloma? If you're over 50, we typically see it in people that are over 50. You see it more in male than you do in female, even though it can happen with both. A lot of times you see it more often in black, non-Hispanic men, more so than the other. The other thing, that this is one of those blood cancers that if there has been some prior radiation exposure, that could be it. And where we're seeing this is that our folks that were in the military and they got exposed to Agent Orange and all those other chemicals and radiation as a part of being in war. We see a lot of that in that particular age group. The other thing that we're seeing, and I was kind of surprised about this, are firefighters. Long-term firefighters that have a lot of exposure to fire, and in those fires, there are a lot of chemicals that come out of those materials when they're being burned. And so they're seeing in firefighters, lifelong firefighters, that you're seeing an increased incidence or an increased number of firefighters that are coming down with multiple myeloma. That was a neat one for me when I did this research setting this up. But think about it, they go to fires, 2 on, 3 off, whatever, they go to fires every day. The burning of whatever that material is, there's a smell, there's an odor, there's chemicals that come along with that. So over a lifetime of exposure to that, they're seeing increased numbers of firefighters being diagnosed with myeloma. So what are the signs and symptoms? Yes, ma'am.
I've heard that people with diabetes can be susceptible to multiple
It's not the diabetes that makes them susceptible. Multiple myeloma is a totally different entity, but what ends up happening is that if you have diabetes, then your whole immune system is just not 100%, but it's not something that predisposes you for multiple myeloma. Multiple myeloma will make your diabetes worse. It will make your bones worse, but it also can present as far as very, very toxic to your kidneys. Because what ends up happening with these multiple myelomas, when they form these lesions in your bones, or they take over your bones and they push the calcium out of your bones, then what happens, that calcium has to go through your kidneys. And a lot of times people present with kidney failure, and they don't know why their kidneys are failing. There's too much calcium in the blood and they can't manage it. So there are lots of symptoms that go along with it. But you don't think, oh, I have multiple myeloma. Nobody thinks that. Nobody thinks that. So you go to the doctor with symptoms of, I'm tired all the time, I got infections, it's from the white blood cell line that fights infection, that's your immune system. So you get infections really, really easily. But the other thing that's a little different from this one, unlike leukemia, doesn't necessarily cause a lot of pain. Lymphoma, depending on where it is, doesn't really cause a lot of pain. Multiple myeloma, once it gets in your bones, will hurt. It will hurt. It does cause pain, especially on what we call your pressure bones. When you're standing up in your hips, in your legs, anything that you have pressure in, like if you lay on your shoulder, you lay on your arm, anything that puts pressure on that area that's already weakened by multiple myeloma is going to hurt. So that's this one, this blood cancer, or this cancer that originates from the white blood cell, can and does cause pain. A lot of times people go and say, oh, I just got bad arthritis, and arthritis got worse. Arthritis didn't make that happen. That's a whole different process. So a lot of times, and this is the thing, you may have arthritis, but you can have arthritis and it has nothing to do with multiple myeloma, but the kind of pain, that achiness. But the thing about multiple myeloma typically is one area that's going to hurt that wasn't hurting before. That wasn't hurting before. We all got stuff now. You have to think about it when you want to move. When you got to think about it. You got to rock a little bit. You know that happens. That comes with seasoning. That's what I call it, seasoning. That just comes as a part of it. But multiple myeloma is a different kind of ache. It's a different kind of pain. So I don't want you guys to leave here thinking just because I'm aching and I'm hurting, I got multiple myeloma. No, don't do that. I saw it in your face. That's what I'm saying. That's not what I'm saying. This is something different. This is not your normal. This is something that you had your baseline, whatever your baseline was, and all of a sudden this is something new, and it's generally, your regular pain is here, this is going to be here. And it's going to be in one spot. So that's a different thing. That's a different animal. I don't want anybody leaving here tonight thinking just because we get hurt and I got myeloma. That's not the case. All right? No, don't do it. Yes, ma'am.
I didn't have a question, I just wanted to tell you that, that's what I had.
Multiple myeloma. How did you get diagnosed, if you don't mind me asking?
Serum electrophoresis.
But what made you go to the doctor in the first place?
Persistent anemia, and frequent pathological fractures.
That's it.
Spine and my ankle, and they repaired my ankle, and I went like maybe 2 to 3 years with anemia, trying different things, different types of medication.
And nothing fixed.
Nothing fixed it, and I kept asking the doctors. I went to a neurologist before my back. I had a spinal fracture. I went to my endocrinologist. My foot was aching. They said I had a plantar fasciitis. Okay, it never got better, and I said, this is not the same. And so finally, when I went to the orthopedist for my foot, he said, well, your plantar fasciitis is going to ache here. I said, that's not where it's aching. So he finally x-rayed my foot, and he just said I have undetermined fractured ankle. So when I went to my gynecologist, she said, how long have you been anemic? I said, 3 years. And she said, well, I'm going to send you to a hematologist, oncologist. And she was the one who did the serum electrophoresis, and then we did a bone marrow biopsy and a PET scan.
That's it. And that's one of the problems with multiple myeloma. Unlike leukemia is not something that people don't poo-poo by. When you draw that blood, you see the blast cell, that's going to get you straight to go. Multiple myeloma, though, is so insidious, it's kind of slow and it's sneaky. Because you can treat anemia for a long time. And you just, everybody's a little bit anemic. You're getting a little older, you're a little anemic, so they just kind of kept going. You're hurting, you're aching, and then the fact that nobody thought to send you somewhere. And that's the problem with multiple myeloma, is that because the symptoms start out the way hers did, the anemia, getting infection. When she said pathological fracture, she was breaking bones, it wasn't falling, wasn't in no car wreck. She just get up one day and put pressure on her ankle and it started hurting because it broke. Bending your back or lifting something, picking something up with those, what they call lytic lesions in your bones, it makes them mushy. They mushy and they'll break with at least a little bit of pressure. So I hate that, that's the problem with multiple myeloma, because you can treat symptoms for a long time. And so what was happening during that long time, that 3 years, multiple myeloma was growing. It wasn't sitting still. So it had more opportunity to affect more bones in her body. So she had problems with her back. She had problems with her ankle. She has problems with anemia. She probably had problems with getting over infections. All of those things, but it was just enough to keep them bumping her back and forth to all these different doctors. That's the problem with multiple myeloma. The others, the way that they present is like in your face. You cannot ignore it. You can ignore it for a little while, but you will not be able to ignore it for long. Not that you ignore it, but you can't pass it off as something else. Multiple myeloma is so slow. I call it sneaky. It's sneaky because it'll come these mild, what people think are mild, it's just your age. You're just getting older, so that's why you hurt. But it was different. It's different from arthritis because you're not breaking bones when you sit down or when you stand up, or if you put your foot down, your ankle didn't break, your back didn't break, you probably got wrist problems too. They may not be broken, so everything. So I'm so glad you're here. See, you adding. See, I just thank God just adds to the flavor every time when you do stuff and you do it the right way. So your process, your 3 years to getting diagnosed, finally getting to a hematologist. And so what the hematologist did, because when you look at that on a regular x-ray, it doesn't look bad until you start doing those other scans. Because unless it's broke, then you don't really see anything any different. You got to get those what they call high resolution kind of things. You got to get PET scans and MRIs and all these other kind of scans that gives you more definition to look at those bones to see. They call them hot spots. Hot spots, because they light up on certain scans. They don't light up on regular x-rays. but they'll light up on these special scans. So the other thing is she did those scans and she lit up like a Christmas tree, and then they drew some blood, and so there are proteins that if you draw those proteins, if you draw blood and there's an elevation, what is it, an M and IgG? Which one?
14.
Yes, so they draw blood, but you don't know to draw the blood. It doesn't, they don't order, you have to specifically order that. It doesn't, like, if you draw a CBC with leukemia, those black baby cells are gonna show up. Unless you specifically know to ask for that particular protein to run a lab on it, they don't check for it because it's not a part of routine lab. But going to a hematologist, seeing those bones light up and having a history of anemia and lighting up on the bones, you need to draw that. So what they're doing for her, whatever her treatment is, they're following her blood to see what that protein is doing. They follow that protein. So depending on what her protein level is, that's going to determine whether she's on medicine, whether she's off medicine. So multiple myeloma is not a disease that we're curing. We can control it. It'll spike up, it'll spike down. So you treat it, give it a break for a minute, watch those proteins. When they start sneaking back up, you get to put back on some more medicine. Now, multiple myeloma is one of those diseases where we have had an explosion of all of these new drugs, these biotherapies. There's, oh my God, every day. That's good news because honestly, when I first started oncology nursing, the life expectancy for people with multiple myeloma was 6 months to a year. That was it. It's indefinite now. We don't put a time on it. 5 years, if someone lived 5 years with multiple myeloma, that was a miracle. It's an expectation of that and more now. It's just like having high blood pressure. Actually, cancer now is listed as a chronic disease. I work with Mr. Bora in Mississippi Companies in Cancer Control. One of the things that we talk about is cancer is a chronic disease for a lot of people. It's like having high blood pressure. You manage it. Sometimes you manage it well and you keep it controlled. Other times, like her husband, it's not controlled, it's not well managed. And it depends on the disease. It is very dependent upon what disease you have as to whether or not it can or will be managed. I thank God for coverage. I thank God for all the new technology. And I particularly thank Him for having people out there that know how to use that technology. The thing, though, that I hate to hear is those stories like that. When you have someone that has anemia for 3 years and you've been treated for 3 years and it didn't respond, somebody somewhere, in my opinion, should have woke up and said, let's send her, this is something that's not responding. You need to go somewhere else. Somebody that knows about blood. And that's the thing. With all of these blood cancers, oncologists, we have some great oncologists in the central Mississippi area. We also have now, there are specific cancer doctors that do everything. And then you also have specific cancer doctors that the only thing that they do are blood cancers. They're called hematologists. So with these blood cancers, yes, you can be treated by a regular oncologist because they do everything. But you know, I come from a world at university where they have a whole group of doctors that all they do is take care of these blood and lymph node type cancers because that's what they see every day. So that's a different world. I don't say anybody's good or worse or better than others. I just say make sure if you have someone that's in that situation, don't just take a pat on the head and take another iron pill or take another iron infusion that doesn't work. If it doesn't work, that needs to be something that's done. Anemia that's unresponding for a year, and this lady did for 3 years, somebody dropped the ball, in my opinion. Just say.
Keep asking questions. I was asking questions, and I'm at LPN, so I kept asking questions. And I know if you have a pathological practice, there's something causing it. But I was told several times there's no signs of any kind of cancer or any kind of, metastasis or anything. And I said, well, there's something different. But I made it through, and I had a stem cell transplant back in February. So right now I'm in admission. Thank you God for that.
Again,
But like I tell everybody, don't just take one doctor's word.
no.
And ask questions and look for yourself different things, but ask
You have to
questions.
be an advocate for yourself.
Ask yourself. support.
And the one thing I would say is that if you get nothing else from this, if you have those nagging, prolonged, and I remember there's a physician, I was at a conference one time, she's a pulmonologist. She said the Lord gave you 5 senses, but she said all of a sudden we got a 6th one. That 6th sense is that something ain't right. When something ain't right, when something ain't right, don't let somebody tell you that you dreaming it or you think something ain't right. And you keep going and you keep asking those questions. There will, hopefully and prayerfully, we won't keep hearing stories like this, and hopefully and prayerfully, we will have people being funneled in the right way and in the right place. But I really wanted to share about these things that at times, because it's not the norm, it doesn't show up on x-rays, it doesn't show up when you do colonoscopy. These kind of cancers don't show up like that. You have to know the specific kind of test to do in order to get these things to show up, the particular kind of blood work to look for in order to diagnose them. I will say that there is hope. There are things out there that you can do. So I just want to say some takeaways, and I put this on that last page. We've come a long way in cancer care, but not all cancers have a routine screening. Not all cancers have something that you can do to prevent it, exercising and eating right and colonoscopy. Some of these cancers that doesn't even touch these cancers that we're talking about. The main thing that you can do is be aware of your health, and if something changes, go get checked out. If something ain't right. Something ain't right. That 6th sense that tells you in your gut something's not right. Share your family medical history. That's important. Earlier when we were talking about thyroid disease versus thyroid cancer, it is important to have those conversations with your family. My personal family history is that my grandmother had colon cancer, had chemo and all of that. My mom was diagnosed with early stage colon cancer. She never had to have surgery or chemo. So what did that mean for me? What that meant for me is that at the age of 40, with my family history, and I'm 64, so back when I was 40, I had my first colonoscopy, and that's before they changed the standards, because of my family history. What does that mean for my children? Those 3 children I'm so blessed to have. My children know that they started colonoscopies at age 40. My 42-year-old son, when he had his first colonoscopy, he had 2 polyps removed. 2 polyps are early cancers. If he had left them there until he was 45, it probably would have been cancer. My 41-year-old daughter had her first colonoscopy. She had a polyp. So we need to have these conversations with our family. We need to talk to our children. We come from folks here in the South. We don't talk about what mom had, what Mother had. We don't know she had female problems. Papa had male problems and all. We don't talk about it. We need to talk about what went on in the family, what is going, what you see in your family. So make sure you talk about your own medical history. Now, I have to say, I have to confess, I'm bad about that. My husband, he said, you don't tell me nothing. You got all these pills in there, what you taking them for? I'm not a complainer, but I got to do better. Talk to people about what's going on with you medically. Let your children know if you're taking a certain medicine for certain. Let your husband know, whomever knows. Somebody needs to know why you got that whole line of pills in your bathroom. Somebody needs to know. I'm back. I'm talking to the choir. Lord knows I need to do better. I'm confessing. There are new therapies to treat and manage these diseases, but make yourself a priority. Don't let someone poo-poo your way. Always ask those questions. Always stand up for yourself and keep asking for those answers. And keep asking. They don't get irritated. They don't get tired. That's okay. That's okay. Just keep asking, keep pushing. And I love this poem because I always leave this poem and I share it whenever I get an opportunity to speak with folks. It's called Your Garden of Daily Living. As we proceed, we will be planting a garden, hopefully a garden that will help you move towards or maintain balance in your life. Plant 4 rows of squash. Squash inactivity, squash indifference, squash grumbling, squash negativity. Plant 3 rows of peas. Peace of mind, peace of heart, and peace of soul. No garden is complete without turnips. Turn up for appointments, turn up for opportunities, and turn up to help someone else. Plant 4 rows of lettuce. Let us be faithful. Let us be kind. Let us be patient. Let us really love one another. Let us also have time. Time for yourself, time for family, time for friends. Final garden instructions. Water freely, with patience, and cultivate with love. There's much fruit in your garden, but remember, you reap what you sow. Anybody have any other questions or anything you just want to ask?
I would like to ask, because, like I said, it seems like so much taxpaying what you were saying. Is there any particular study or something that says that any one cancer is more difficult to treat than others? Which one is the most difficult to treat?
The cancers that are most difficult to treat are the blood and lymph node cancers. Just because it's all or none, there's not a little bit of it. There's no such thing as a little bit of leukemia. There's no such thing as a little bit of myeloma, and no such thing as a little bit of lymphoma. Either you have it or you don't.
Yes, my brother passed away with blood cancer. And like you're saying, it came back all of a sudden, we didn't realize what was going on.
There are some cancers that are difficult to treat, especially on the solid tumor side when you leave the blood cancer. The cancers that we don't have a screening for, and that we typically don't find them until they have grown and maybe start having symptoms. Those are the cancers that are difficult to treat. Things like pancreatic cancer, things like gastric cancer, things like ovarian cancer, depending on where it is, because we don't have screenings for those 3 types of cancers. And by the time you go because you have symptoms, you don't have symptoms until the disease is spread a whole lot. So we don't do as well with those diseases unless you happen to find it early, and some people are blessed with that. But those cancers where we don't have a screening, where we can find it early, or depending on what the diagnosis, there's some diagnoses with these lymph node and blood cancers that if you find it and you treat it, like Hodgkin's lymphoma with younger people, they actually do very well with that. Young children that are diagnosed with acute leukemia, especially ALL, they do well. But some of the others are just bad players. AML is not a good player. He just does not play nice. Whereas PML, which is another acute leukemia, it actually responds better to treatment. That's the thing. So a lot of it also depends on what stage. Now with the blood cancers, it's all or none pretty much. With the other cancers, it depends on how much disease is found at the time that you're diagnosed. Whether you have a little bit or whether you have a lot and it's spread to a lot of different places. That makes a huge difference. Yes, ma'am.
You know, my dad died in 1981. And I was going around saying he had bone cancer. But now I'm going around he had blood cancer.
You could have. Now you can have bone marrow. You can have bone cancer, but it may have been multiple myeloma because it was in his bones. So it would be nice to know that. I don't know how you can find that out because a lot of times people call multiple myeloma bone cancer. It's different. You can have a primary bone cancer. A lot of young people will tend to have a lot of bone cancers because that's where you see young people that have limbs that are cut off. And those are typically diseases called sarcoma, though. That's a different kind of cancer. It's a solid tumor, but it can manifest in the bones and in the muscles, and they will have those limbs cut off. But that's an interesting thing to find out, if you're able to find out.
But it's spread throughout his body with rapidly.
So it could have been multiple myeloma at this point, unless you have access to his doctor, and you probably won't know.
One last question, going back to leukemia. I was always told that leukemia was painful.
Leukemia itself is not painful because the side effects of having leukemia are fatigue, shortness of breath, and you don't get over infections. If you have a wound, it will not heal, it won't get better. So it's not the leukemia itself, it depends on how you manifest it, how it comes about. So if you go to the dentist and get a tooth pulled, if you have leukemia, it's not going to heal, and it will hurt. So for the most part, most of the time, it's true leukemia itself does not hurt. Now, what we do as far as treatment will make you hurt. The side effects of treatment make you hurt, but the disease itself does not cause, typically, every day is a new day. Typically at presentation, it's not the disease that's making you hurt, it's whatever symptom you're presenting with that could potentially make you hurt, but the leukemia itself doesn't necessarily do that. Yes, sir.
Is lupus, how does lupus fit into this?
Lupus is what they call an autoimmune disorder. So it affects your immune system. It is not categorized as a cancer, but it will affect your immune system so that your body can't fight infection, and then you can die from an overwhelming infection. But it is what they call an autoimmune, meaning that your immune system, it turns it off and it doesn't let it work the way it's supposed to. So people with lupus have problems with their blood and they have problems with ongoing infection. So it's not categorized as a pure cancer itself. Now, lupus is taken care of by hematologists. Hematologists take care of people with lupus, but it is not something that you can cure. You have lupus and you just basically get it controlled, but it's not under the category of a cancer. It's a disorder. But it presents a lot of times like a lot of the other blood cancers and blood disorders.
So it's not a blood cancer?
It's not a blood cancer, it's a disorder of the immune system.
Okay.
So it's a splitting hairs. It's splitting hairs, but it affects your immune system, which affects how your blood cells are used. So that's why they have all that fatigue and infections and all that stuff going on with lupus.
I just wanted to ask a question now. If I remember my anatomy, you mentioned ovarian cancer, but I understood that you don't have to have ovaries to get ovarian cancer, even to the ladies who have them removed, because that tissue have doing, reproduction and everything, you still can get ovarian cancer. So
If you have had your ovaries removed and they are completely gone, if there's any residual ovary tissue left, it can happen there, but if you get them removed, then that decreases your risk factor of getting them. But the thing is that women that have hysterectomies, a lot of times they don't get their ovaries removed and the ovaries are left. In my case, as a younger woman, I had a hysterectomy in my 30s. And because I was so young, they left my ovaries in, and I got to a certain age, I'm like, I don't need this. That just opened up the window for something else. So I went back a few years ago. I actually were having some other problems, but I had my ovaries removed. They weren't working. I was on the other side of 60. They weren't working anyway. So, and they were just kind of hanging out. Could have caused me some more problems. So I had them removed. Yes, ma'am.
So like a lot of us in here are older women, and I know when I went to the doctor a couple of years ago, she said, quote unquote, your ovaries are shrinking nicely.
Yes. So what that means is that as we age, the thing about ovaries and the eggs that are in your body, the amount of ovaries that you have when you're born are that you have them, that's the most you're going to ever have. And throughout the rest of your life, the number and the amount of ovaries that you have actually decrease. So as you age, they shrink and they get smaller, which is good rather than being plump, because they should shrink and go away. If they got bigger, they'll stay big and plump, that would be suspicious for something going on, either cyst or something like that. So that means that's a natural process for the ovaries, that basically they decline in function, they shrink and get smaller. And they basically don't have any function. And the whole point was to give you the hormonal balance, and as we get seasoning in our lives, that hormonal balance goes away.
And I just want to say to our Christian congregation here, that when I heard that quote about steroid,
Yeah, Lord.
And I'm like, God did
That was a God thing. God did that.
She had that little slunky old.
That's right. You know, the reality is we all grown folks, she was not having a cycle in her mind. That was not happening. And in order to have a baby, you need to be having a cycle because you're passing those eggs. That's a God thing. That's how we know God does it. God still does it. That's why folks say, if that happened to me, God would really work something out. Thank y'all so much. I enjoyed it.
I want to thank everyone for coming out tonight. Did you guys enjoy Mrs. Wells? Did you leave informed? You got to educate and tell someone else? Yes? Okay, all right. Well, Mrs. Wells, I want to thank you again for taking time out of your busy schedule and coming through for us. And I have a little token of appreciation if you'll come up. Although she's retired, she still works a little bit, and so
I think people retirement didn't pay.
I just want to be mindful of everyone's time. Thank you so much.
It's my sister from another.
Okay, and so that's going to conclude. I'm going to have Pastor come up and give us a closing prayer. And all of you that attended tonight, if you'll come up and you'll get one of these cups. And for those of you that did not sign in, I need you to sign in. I'll have the sign-in sheet up here. And so once again, thank you all. And we'll be doing more of these in the near future.
I'd like to thank the speaker first of all, Mrs. Wells. Thank you for the information. Thank y'all for your participation. And a lot of interesting stuff. Looking at his body, how God made it, all that mercy. I got a lot of especially from the sermon. Father, thank you for our sermon of the night. We just praise you for those that came out. Yes, we shall have mercy. And that they will go through that destination safely. And I pray that something was said that they can use for their education, especially in that health situation, and even in their family. We thank you for this in Jesus'